My name is Jim Walsh. I'm, as you guys know, the medical director up at the Addiction Recovery Service on 5 South, and I was asked to talk about alcohol withdrawal. I want to kind of talk about how I've been thinking about it more in the hopes that this will kind of inform why we're doing what we're doing and help you guys make those everyday decisions you have to make. Okay, there's more people coming. Okay. So, can that be lowered a little bit? So, alcohol withdrawal, to me, is like this horrible storm of brain activity. There's kind of like a tipping point where it becomes a positive feedback cycle. Things escalate and get worse and worse and worse. It's a positive feedback state in the way that a seizure is, in the way that the primary addiction can be, in the sense that the more alcohol withdrawal you're having, in a way the worse it can make the brain, and things can escalate out of control. The cause of this whole cycle, of this escalation out of control, is a lack of inhibition, which we'll talk about some more. So in the brain, there's a balance of inhibitory activity and excitatory activity. And these are probably the two most important neurotransmitters that do that. But if you think about it, things always have to be in a balance. And if things tip out of the balance, a positive feedback state where things escalate progressively out of control can occur. Alcohol works, let me do this, go back a second. So GABA, or gamma-aminobutyric acid, is a small little molecule, an amino acid, that is the most important inhibitory neurotransmitter. So when GABA binds to a nerve cell, that nerve cell becomes less likely to fire an action potential. It calms that nerve cell down. And the brain is full of these GABA receptors and GABA neurotransmitters that are basically there to calm things down all the time. And you need this to not be a crazy person having a seizure. Okay. Alcohol is basically GABA. It does a lot of other things in the brain. It's a small molecule, a complicated molecule, but it binds to that GABA receptor. It opens up that neurotransmitter. That cell becomes less likely to fire, and the whole brain gets turned down a little bit, which would be wonderful if that's the effect that you're looking for. However, when you're providing this extra alcohol, this extra GABA activity regularly, the brain gets used to it. Right? The brain is very good at dealing with slow changes and returning to its normal equilibrium. So if you're drinking alcohol or taking anything that increases your GABA activity, the inhibition of your brain will respond by compensating, by ratcheting that whole system down to return to a balance. Right? So when you're drinking regularly, the presence of this GABA drug, this inhibitory drug, leads to an inactivation, a reduction of the GABA system in some way. We think that the receptors are taken away or turned off in some way. So you have alcohol trying to make you sleepy, right? But you have a reduction in receptors, and you come back to your natural balance. So that's why a guy can be walking around drinking with an alcohol level of 280, functioning, looking perfectly normal. He's in fact returned to balance. But when the drinking stops, suddenly things go all screwy. You have a deficiency of inhibition. Your brain has basically gotten used to the alcohol being there to provide the right amount of GABA activity. You take the brain out, and your brain is suddenly lacking inhibition, which is the same as being overstimulated, right? And just like a small spark can cause a seizure, right? This lack of inhibition can lead to a storm of positive feedback that is alcohol withdrawal. I was asked to kind of break it down into 3 categories. We can look at the symptoms of early withdrawal, which we all see regularly in any hospital setting, the sweating and the shaking and the anxiety. In moderate withdrawal, this gets a little bit worse. These are not absolute categories, obviously. They're just kind of a rough sense of how to break things apart. In severe withdrawal, I don't know if I have a pointer. In severe withdrawal, things can get very bad. Pay attention to agitation, disorientation, and hallucinations. That's DTs, right? But a lot of other stuff is going on there. High blood pressure, tachycardia, fever, sweating. That's going to cause dehydration and renal dysfunction. Right? People are tremulous and discoordinated, which can cause aspiration. And a lot of things can go wrong there that culminate in death. So people die from severe alcohol withdrawal. Okay. Seizures are what we often worry about. Seizures typically occur relatively early in the process, and they're actually surprisingly benign. We don't like it when patients have seizures in the hospital. It looks scary. It looks risky. Some of us have seen seizures recently. But they're preventable pretty easily. They can occur when the alcohol level is still quite high. If someone's gotten used to walking around with an alcohol level of 280, an alcohol level of 120, which is still over the legal limit, might be enough to have that person in withdrawal, shaking, and go ahead and proceed to seizures. Benzodiazepines are Ativan, Valium, Librium, proven to prevent these seizures very, very effectively. Okay? Seizures are going to be more likely in patients, sounds obvious, who've had a seizure before. They've demonstrated a lower threshold to have seizures. They're also more prominent in people who've been in withdrawal a lot. Alcohol withdrawal is sometimes called a kindled phenomenon, meaning that each time you get alcohol withdrawal, you're more likely to get alcohol withdrawal worse the next time. Seizures are like that too. Each time you get a seizure, you set yourself up for more seizures. So the more time this person's experienced alcohol withdrawal, the worse they get. And for people who are also coming off benzodiazepines or other sedatives or other drugs that work at the GABA receptor, it's not surprising things are going to be worse. They're more likely to seize. Okay? Delirium tremens is what we should be more worried about. This is a potentially fatal condition. This shows up later. It escalates over time. It can have a subtle beginning with a guy who's irritable and impatient, but it can progress to severe agitation, delirium, and all the cardiovascular things we're concerned about. The old mortality used to be reported at 15 to 30%. Right? With proper regular treatment, the mortality is quite a bit less than that, but people still die of alcohol withdrawal. Okay? Again, people who've had DTs before, people who are coming off benzos or other sedatives, people who've been in the hospital a lot get it. But elderly people, people who are concurrently ill, who will come in with pneumonia or with a broken leg, are much more likely to have alcohol withdrawal, DTs. People who have high alcohol levels or people who present with a seizure are shown to have a high risk of DTs. We believe that adequate treatment with benzodiazepines prevents DTs. That seems to be true, although it's kind of hard to prove it. So our goal is really to prevent this from happening. Okay. There's a lot of other things we're supposed to prevent. Most of these things are actually preventable by good nursing care. So the nurses are really the people who prevent these kinds of dangerous issues and prevent a lot of fatalities, actually. I'll go over these things briefly, but these are things we really don't want to forget as we're doing all the other stuff that needs to happen. Wernicke's encephalopathy is really a thiamine deficiency, sometimes called Korsakoff's dementia, right? People who are drinking alcohol have an injury to the lining of their stomach that make it hard to absorb B vitamins. So they're thiamine deficient. This is especially true in the guy who's not been eating for the last week. When people who are thiamine deficient get a sudden load of glucose, usually in the IV route, like D5W or D5NS, they can precipitate this encephalopathy. I've never seen a case, and we should prevent every single case, and hopefully you'll never see a case, giving thiamine before people get sugar prevents this. This is why the thiamine orders are written to do before eating, or don't let the person eat till they have their thiamine. This happens so automatically, like good things should happen in the healthcare system, that this really basically never happens unless a terrible mistake occurs. It would be hard to see this. The person is delirious, they're shaky, there are apparently some atypical eyeball movements. The eyes can move in an irregular way that I've fortunately never run into. But our goal is to prevent this by giving thiamine before the person eats, and most importantly, before D5 containing IV fluids are given. And in our unit, I try not to use glucose-containing fluids whenever possible. Okay? Aspiration pneumonia, I used to think is the most common way of people dying in alcohol withdrawal. It's certainly a complication we see often. When you're in alcohol withdrawal, your nervous system isn't working properly. You're discoordinated, so you fall, but your airway is just as discoordinated. So when you swallow, things can go into your lungs. The withdrawal can cause it, but to make it worse, the medicines we give for the withdrawal can cause it by making people less careful and more discoordinated. So this is a really important thing to watch for. Nurses, if they have the opportunity to watch people eat, should notice when this is happening. So if you're feeding somebody, someone's drinking a glass of water, they gag, cough, sputter, something isn't right, and we need to stop them from eating at that moment and take a step back and reevaluate. The thing you're most likely to aspirate are thin liquids. A glass of water, the most risky thing. Okay. So if you have some doubts and you can't get a professional swallowable valve, you can use thickened liquids, which are much, much, much safer than thin liquids. But ideally, you'll keep the person NPO until you can get the swallowable valve to kind of see what they can safely swallow. And again, nursing care is going to prevent this. Just like falls. So falls are a definite risk. People can get intracerebral bleeds. A lot of bad things can happen. We want to have our patients not fall. And just like noticing how they drink water makes them not aspirate, knowing how they get out of bed makes them not fall. A sitter, occasionally restraints are necessary to keep this at bay. But I think the physical therapist is the best friend we have here for two reasons. One is they'll orient the person to use a walker or a cane as safely needed. But more importantly, they'll tire them out. So patients are restless laying in bed. If we give them a chance to walk with the therapist, they'll be less likely to climb out of bed every 5 minutes. So I try to get the therapist there for all these people at the first sign that they're unstable, and I think that makes a big difference. Rhabdomyolysis is a potentially dangerous condition. We don't see it that often, but we don't check for it. Rhabdomyolysis is Greek for breaking open your muscle cells. And when people are really dehydrated, feverish, rapid heartbeat, and for something specific to alcohol withdrawal we don't understand, people will get this breakdown of their red blood cells, of their muscle cells. This is, again, something a nurse might notice, because the reason that this is a dangerous condition is the myoglobin inside your muscle cells gums up your kidneys. It comes out in your pee and it causes kidney disease. And you'll notice a kind of reddish discoloration to the urine on this. If you look at a urinalysis results, you'll see it's heme positive, but blood cell negative, because the myoglobin fires off the heme result, but there's no actual cells because these cells are broken open. So anytime you see that result in a UA, if you're looking at results, heme positive, RBCs negative, we should be looking for this. The cure for this is very simple, aggressive IV fluids. But people can get kidney failure from this. It's more likely in the old guy in bad DTs, someone who's been laying on the ground for a few hours, but especially somebody who has bad kidneys out of the get-go, we want to watch for this. So if someone's with a high BUN, a high creatinine, we want to be looking for this. The test to prove if someone has rhabdomyolysis is a total CPK. That's not something we order routinely, so we order it if we think of it. But if you have someone with renal function who looks real sick, or especially if we have those UA findings, we want to think of that. DVT, I think, is a hard one for me, because people are in bed for a long time if they're in bad DTs. Sometimes they're restrained, sometimes they can't walk safely, and they would seem to be at risk for DVT. At the same time, our patients can be a little bit anticoagulated spontaneously if they're drinking. Their platelets are low, their PT, their prothrombin times can be low, and it's never been clear to me what their risk of DVT is. I've looked for research articles that isolate alcohol patients. I've never found anything. They're definitely at risk for bleeding, so it's a tricky decision whether to anticoagulate somebody, but it's a no-brainer to put stockings on them or sequential compression devices, right, and to get them moving as fast as possible. And I find that nurses usually drive doctors to think about this, so please think about this if you have someone not getting out of bed and nudge the doctor to do something about it. Arrhythmia and MI is kind of a scary affair because there can be very little warning. And this may, in fact, be the most common cause of death in alcohol withdrawal. The only death we've ever had on our unit was probably arrhythmia-induced. The heart is beating fast, the adrenaline is pushing hard, electrolytes are often abnormal, and this can lead to irregular heartbeats that can be abruptly and suddenly fatal. It is not a common thing, but it does occur, and it's hard to get a warning sign of it. Keeping electrolytes normal, potassium, magnesium, is probably the most effective thing we can do to prevent this. Keeping people well hydrated. But also keeping their alcohol withdrawal at bay, treating them aggressively when they're in withdrawal is really, really important. So we want to pay attention to people's hydration status and think about who's at high risk for this. The other thing that causes arrhythmia is other medications. So there's something called Torsades de Pointes and long QT interval. Do you guys all familiar with that, all the nursing staff? So a number of medicines that we use pretty routinely can prolong the QT interval and create risks for this. If we're giving a lot of meds like that, some places will recommend monitoring EKGs to check those QT intervals more frequently. And of course, people can get a heart attack. And we admit a lot of people who've had a CABG before, they've had a bypass surgery, they've had a previous MI, and again, they're dehydrated, they're hot, their heart's beating fast, it's definitely cardiac stress. Beta blockers probably help lower this risk, but treating their underlying alcohol withdrawal is probably the most effective thing. Okay? So coming back to the withdrawal, when the drinking stops, there's a deficiency, a lack of the normal GABA balance. The nervous system is under-inhibited, so it's overstimulated. What are we going to do to help this person? We're basically going to replace the GABA inhibition that's missing. We're going to basically give them the drug that they're used to, or a comparable drug, and slowly wean them down. I mentioned this last question down at the bottom. If we're weaning them down, why not just wean yourself down? Why bother coming to the hospital? If we give Valium and Valium works similar to alcohol, can't you just wean yourself down with alcohol? Right? And that's a question I ponder occasionally, but to think that kind of shows that kind of a lack of grasp of the situation the patient is in. Because the essence of alcoholism is that you can't wean yourself down, right? You can't control it. Everyone you meet with alcohol withdrawal has tried diligently a dozen times to wean themselves down. There's a loss of control. Occasionally a buddy will wean somebody down with a bottle of whiskey, right? But you could never do that for yourself, and you really need some external help. If we're going to wean them down, we have these questions to ask. What are we going to give them? When are we going to give it? And most importantly, how much are we going to give? And that's a challenge. What we're going to give are drugs that work at the GABA receptor. They're basically taking the place of the alcohol. They basically work the same as the alcohol. And benzodiazepines are what we use most commonly, although there are some alternatives as well. So Ativan or lorazepam is used typically in the medical floor. We typically use Librium. It's hard to say chlordiazepoxide, right? And some places like to use Valium. Barbiturates also work at the GABA receptor. In some ways, they can be more potent, and those are used in some places. They have a higher risk of respiratory depression and overdose. And baclofen kind of works at a slightly different GABA receptor, and some places give that. Propofol, which is used in the operating room to make you go completely unconscious, probably works at the GABA receptor and may, in fact, be very effective for alcohol withdrawal, although it's very easy to make someone stop breathing with propofol, so we won't use it in our unit. Okay. People spend a lot of time on, should we give Valium? Should we give Librium? Should we give Ativan? In truth, it doesn't matter that much because they all do the same thing. They bind to the GABA receptor, they activate the GABA receptor, and they kind of suppress nerve activity. But they do have some differences. And the really two differences are how fast they kick in and how fast they wear off. How fast they kick in for any drug is determined by how fat soluble it is, because our brain has got a lot of fat in it, right? How fast they wear off is determined by how quick your liver gets rid of it. So Ativan and Valium kick in fast. Valium and Librium wear off slow. And these all have advantages and disadvantages. Drugs that kick in slow are better, because drugs that kick in fast are very rewarding, very reinforcing, and they make you want more. People smoke their cigarettes rather than eat their tobacco because the suddenness of it kicking in through your lungs is really powerful, right? So people like drugs that kick in fast, and they're going to ask you for more of them. So slow drugs are better, but fast drugs are better. Fast drugs are better when someone's really sick. They have a CWIS score of 35, and they're shaken, and they're combative. You don't want to use a slow drug. So each has a role. Drugs that wear off slow are better. If we're trying to wean somebody off, we don't want a roller coaster ride. We want a slow, steady decline down, right? But drugs that wear off slow can be bad too, because if we give too much and we kind of overshoot a little bit with Librium, that guy might not wake up till Thursday. If we overshoot with Ativan, they'll wake up in the morning, right? So it really depends on your clinical situation. I like drugs that kick in slowly for the vast majority of patients, because they're not going to ask for it as much. They're going to be easier to take care of and be kind of less, kind of engaged in their addiction in a way, right? On the other hand, if someone's very unstable, the fast drugs are going to be our better bet. In our unit, we use the Ativan for the older people because they have slower metabolisms and we don't want to overshoot. People with a bad liver, which to me means jaundice. Short of jaundice, I don't really care that much. They're going to have slow metabolism, but for the majority of patients, we use Librium. A lot of people like Valium best because it lasts a long time and kicks in fast, and some ER settings, Valium can be a really good choice. Again, to me, the fast onset is a disadvantage for Valium. Phenobarb has some special properties, but Phenobarb can be much more potent than barbiturates and can cause more respiratory suppression. So I use it only if we can monitor someone really, really carefully, probably a better drug for the ICU. So, okay. When to give the drug? You want to give it soon. You want to give it now. You want to give it as early as possible. If we think of alcohol withdrawal as the storm of activity, it's almost like you cross a threshold, like the stock market this week, right? And then it's too late, and the storm has already occurred. You want to get it in early, right? Whatever you give, whether it's Ativan or Librium, it's going to wear off a lot slower than alcohol is. So any benzo you give is going to provide a little gentleness to the slope and help prevent some problems. So the answer is early, at the beginning of the patient's problems when you want to give it. Now the big issue is how much to give. And the patient probably wants maybe more than the doctor wants to give. And the nurse, of course, is in the middle of this conversation, right? So I think this is a real challenge when to give. How much to give. We can think of our goals. We definitely don't want them to have a seizure. That feels like an obvious good thing. And we don't want people to go into DTs and die. That's a good thing. We don't want to have complications like an MI, and aggressive treatment of the withdrawal can help lower that. We might want to get rid of all their anxiety. But maybe we don't want to get rid of all their anxiety. That's a complicated choice. I think that's a value decision. We might want to shorten their length of stay. That might seem like a good choice to the patient and certainly to the payer, but not to every patient. There are these conflicting values. Most studies assume that giving less benzodiazepine is a good thing, and I operate from that assumption, but that's a fairly arbitrary assumption. Less anxiety is often the patient's goal, though not always. Sometimes the patient wants less medicine too. And again, the payer always wants a shorter length of stay. Of course, our real goal is to help the patient stay sober. That's our real intention here. It's not clear that these decisions affect that whatsoever. Each patient is definitely different. Many patients don't need any medicine to deal with alcohol withdrawal. Certainly a lot of people quit at home and nothing bad happens, just as other people will get sick and die. Some patient needs enormous amount of benzodiazepines. In the ICU setting, some people will get 20 milligrams of Ativan every hour. Every hour. That's a lot. That's more than we're accustomed to giving, and they often need it. When is it too much? A patient's combative and fighting and sweating and shaky. When is it too much? It's only too much if they're not breathing. Okay? There's no number that ever makes it too much if a patient's in severe DTs. Okay? There can be odd complications about some of the medicines and require intensive monitoring, which the ICU people know how to do, but you should never think it's too much as long as they're breathing. If they're combative, they almost certainly need more medicine. How much is too little? Well, 0 can be plenty for lots of people. It's too little if they have a seizure or go into DTs. So our goal is to prevent these complications. And well, that picture's not big enough. But for this purpose, to figure out how much, we are graced to have a little bit of actual research, kind of a rare thing to find in some of these fields, and that's the CWIS score. So I've told you that some patients need a lot, some patients need a little. All the research studies are really clear that when you individualize the amount of medicine to what the person needs, everybody does better. The patient who needs less, get less medicine, has less complications, get home sooner. The patient who needs more has less likely to have DTs or other complications. So we want to individualize. But what we're monitoring to figure out what they need is symptoms, right? You can't just go ask the patient how much they need. We've told you the patient can't tell you how much they need. They're not able to do that for themselves. So we need to have some objective as possible measurement. The CWIS score looks at 8 different symptoms and asks you to make a numerical assessment of a very subjective reality to generate a number that says how bad their withdrawal is. And what's funny is that with a very little amount of training, this is shown to be a very reliable measure. Okay? In the research studies, people got benzodiazepine if they scored 10 or higher. Right? Now that's different than what you guys do in some of the medical floors, right? 10 or higher, that's relatively high. Now the research studies took patients who had never had a seizure, had never had DTs, were not elderly, and were not otherwise ill. So they took a pretty select population. That may not apply to everybody. Where to give the benzodiazepine at what cutoff can be somewhat controversial. At Ballard, at ARS, we used to always do 10, because that's the research base. One of the nurse managers convinced me to go with 8 for at least the first couple days. And I think she was probably right. I think we've done better since we've done that. On some of the medical floors, they've done 6 as a cutoff. And I've actually sometimes seen people getting benzodiazepines with CWIS scores of 1 or 2, or probably not. Probably that's not what they need. But using this gives you some way of having a handle that probably is true from person to person. I'm going to go through these relatively quickly, and our nurse, Fran, will talk about it more. Nausea is one of the symptoms, and there's your score. Tremors, sweats, anxiety, this is what the patient says they have. Agitation is what you think they have. Tactile disturbances, which go from being itchy to thinking there's bugs on your skin. Auditory disturbances, from like having the noise bother you to thinking people are shouting your name. And visual, similarly, from the lights bothering your eyes to seeing faces out to get you. Headache was often forgotten as a potential symptom. And of course, orientation, how disoriented the patient is. And you just add up all those numbers, and if the score is how you give medicines. And this should work completely automatically, and it almost always does. If we give medicine to the CWIS score, the patient's medical needs will go up for 2 or 3 days, and then it will come down by itself over the next couple of days. And usually without making any change in the regimen, the patient will get better and discharged. And this is clearly the best standardized, established treatment regimen that we can offer. They used to ask a lot of other questions. At first, there were 25 questions. People always ask me, why is there no blood pressure and pulse in that regimen? It was shown that it doesn't, if you do a multifactorial analysis, it kind of falls out. That the questions we have basically capture all the variability from patient to patient. There's a lot of questions about other medicines, and other medicines which we use and believe are very helpful have much less evidence, much less scientific evidence for their use. So some of this seems reasonable, some of this is based on our clinical experience, and there's a little bit of scientific evidence. So anticonvulsants or seizure drugs, okay, have been proven, kind of, to help with the symptoms of alcohol withdrawal. People are less anxious, people sleep better. It's not entirely clear if they prevent seizures. And this goes back to the very early days of when they were discovering what meds help alcohol withdrawal. And they did a wonderful randomized study of patients on Dilantin versus patients on Ativan. And we found that when people get Dilantin, they still seize exactly the same. Dilantin does nothing to help prevent alcohol withdrawal seizures. So when I was in medical school, we were taught that anti-seizure meds don't prevent alcohol withdrawal seizures, that only benzodiazepines will. Right? But then there's these studies that show that Depakote and Tegretol definitely help with the anxiety and insomnia of alcohol withdrawal. So that makes us wonder what role they might have. Dilantin and Depakote and Tegretol are kind of different. There's a whole class of drugs that help bipolar disorder or manic depression. And I remember I mentioned that alcohol withdrawal is a kindled phenomenon, right? Each time you get it, it gets worse the next time. Manic depression's like that too, and seizures are like that too. Each time you get a seizure, you're set up for more seizures, and each time you get manic, you're set up for more mania. And Dilantin doesn't take care of that problem. It doesn't treat bipolar disorder, which all these other guys do. So there's some sense that there's some connection there, right? In the studies that looked in Depakote and Tegretol, they excluded patients who'd ever had a seizure before or seemed very likely to have a seizure. So in those studies, neither the patient nor the placebos or the active patients got any seizures. So there's no data about whether they prevent seizures. But we think they prevent seizures. Or more specifically, I think they prevent seizures. Because we started using these drugs a few years ago in patients who've had seizures before. And the occasional seizures we used to get went away completely. And there's a few specific clinical stories that are fun to talk about that kind of demonstrate to me how they prevent those things. It gets caught up with the benzo withdrawal, so I'll save them for another time. But when we've got these medicines at a therapeutic level, nobody ever has a seizure. Now that's not randomized, it's not placebo-controlled, and it's not really proof. But I believe they'll prevent seizures, and we find them useful in this way. Depakote and Tegretol are the ones that we use. It might be true that Trileptal and Lamictal and Topamax and Neurontin and Lyrica would also be helpful, but we don't know if they're helpful because there's not much evidence. The problem with the anticonvulsants is they do have risk. They have complications and side effects, and drug interactions can be a big problem. So Tegretol can cause Stevens-Johnson syndrome. That's kind of like when all your skin falls off. That's a very bad thing, which is very dangerous, but a fairly rare thing. In all the patients who were studied for alcohol withdrawal with this drug, about 1,000 people, no one ever got that. Right? We've never seen a patient ever have that. I'm told if you see this once, you never forget it in your life. It's a pretty scary phenomenon. Low sodium is a problem. Liver problems can be a problem. And people come in like that all the time, so that's a little concern. But we actually haven't had any trouble with that in our unit. We've had trouble with ataxia. And it seemed to me when we used this Tegretol primarily that about 1 out of every 6 patients would get very wobbly and vertiginous, vertigo, spinning sensation. And that was a real concern. It was especially likely when the patient's level was a little too high. So you see the Tegretol level is 200, the dose is 200 milligrams TID, usually given for 6 days. That's not adjusted per weight. And I don't know how to adjust Tegretol for weight. And we found the small people would get more of this ataxia. So when I use Tegretol, I try to be really careful in those levels. We're aiming for the normal therapeutic levels, just like seizure patients, 6 to 10. Because the weight issue is a problem, I switched more to the Depakote. Depakote's given by weight, 20 mg per kg divided BID. I like that, so it's self-adjusting. But Depakote has problems too. Low platelets can occur, and a lot of our patients have low platelets, liver problems. You can get a kind of a fine, subtle tremor very rarely with Depakote. That's a problem. But the only thing that's really come up in our unit again has been high ammonia levels. And this is something I was never taught in school. There's a literature about this, and only a few people pay much attention to it. But Depakote's been shown to sometimes, rarely make the ammonia levels shoot up very high. We had one patient who was very somnolent. We couldn't wake her up, and she had an ammonia level over 100. She was breathing still, which was fine. That came down over 2 or 3 days with lactulose. But this can be an issue. We've seen it in the 6 years I've been up there about 3 or 4 times as a significant problem. You would assume that's a liver issue because we know patients with bad liver disease get high ammonia levels. But with Depakote, it seems to be more renal. So we monitor this now, and we started doing the levels after a couple days, and so many patients had levels 40 or 50. The normal range was like from 11 to 35. That we were wondering, is it real? Is it significant? So we started checking the before level 2, and most of our alcohol-using patients come in at a level of 40 or 50. But if it gets up towards 100, it can be sedating in some people, so we watch for that. Okay, so those are the seizure drugs. I'm going to mention that I think the seizure drugs are probably most useful in patients who are very highly likely to seize, the patients who've seized before, the patients who are also on Valium or Soma or other sedatives at home. It's also really useful for the patient that it's going to be hard to do a CWIS score. If you think about a CWIS score, I have to ask you a lot of questions and you have to answer my questions. If there's some reason I'm going to have trouble communicating with you because you're psychotic, because we don't speak the same language, but anything that's going to impair our ability to communicate is going to make it hard for me to trust my CWIS score, and I like the Depakote or Tegretol for those patients. So antipsychotics can be very helpful. People definitely feel better if we give them Haldol or Seroquel or Risperdal. They're calmer, their hallucinations get better, they sleep better. They pretty much like it for the most part. That's different than a lot of schizophrenics who don't want to take these medicines. Most of our patients are very happy to take them and feel better, but they don't prevent seizures. In fact, they can raise the risk of seizures. Right? So that's a worrisome concern. If I use Haldol or Seroquel in lieu of, instead of the Librium, I'm going to get in trouble. Something bad's going to happen. If I use it in addition to, it might help. There is another problem with these meds, though. They do prolong the QT interval, which does raise the risk of arrhythmia. Now, this has been shown in studies giving crazy big doses of Haldol. In an ICU setting where someone's on a monitor, they give a 10 milligram Haldol push. That's a lot of Haldol. PO Haldol is much lighter than injections of Haldol, so 10 milligrams of IV Haldol is way more than 10 milligrams of PO Haldol. And they saw a guy go into a dangerous heart rhythm, torsade de pointes, right? There's been a few other trials of sure there are case reports of lower amounts, but still big doses causing these heart rhythms. There's been some data that when people take even the normal therapeutic doses, that elderly people have a slightly higher risk of sudden cardiac death. That's like 1 out of 1,000 or 1 out of 10,000 patients. But still, this is a potential concern. So these medicines are very helpful symptomatically, but we try to be careful with them and not be too excessive. If I'm giving a lot of these meds, I will get an EKG and check their QT interval, or if I think the patient may be at risk for this. But no one really knows exactly when you have to do that. The normal QT interval is like, oh, somebody help me, 400-ish, right? If it's over 400, you should think about it. If it's over 500, that's very high. Okay? Okay. Beta blockers are great. Patients definitely feel better with beta blockers. They feel calmer, they sweat less, they shake less. They'll report that they're helping, but they seize just the same. They don't prevent seizures at all, and they can mask some of what we're doing with our CWIS score. They probably lower the risk of a heart attack because your heart's not beating so fast. That's probably a good thing. They might lower your risk of arrhythmia, but I've seen funny cases where for certain reasons, Torsade is more likely with a slower heart rate, and in other cases less likely. So I'm not sure about that, but they might be helpful from a cardiovascular perspective. I try to make sure we're not giving beta blockers and clonidine in lieu of the benzodiazepine, but again, in addition to. But it's hard to figure that out sometimes. Okay. There's other sedatives we use. We give trazodone in our unit to almost everybody. Trazodone is an antidepressant medicine. It has just a drowsy side effect. That's wonderful when you have insomnia. It's not addictive or habit forming. That's kind of appealing. There's a very bad thing that can happen with trazodone to men only, something called priapism, which is an erection that won't go away and can actually cause very permanent damage. It's incredibly rare. I've never seen a case, but it's scary. But we use trazodone pretty routinely, and most people find it very helpful. People who are manic depressive don't typically respond as well to the trazodone, so we might use something else. We give Vistaril a lot. Vistaril is hydroxyzine. It's an antihistamine, just like Benadryl, kind of like taking a Tylenol PM to help you go to sleep. Not addictive or habit forming. Causes dry mouth, but otherwise pretty benign. Probably not, doesn't seem to me all that potent, but I feel like it mainly gives the patient something to do. I'm anxious, going to have a pill. You don't need any Librium. Well, can you give me something? Sure, you can have a Vistaril. It's fine. And these play a very minor role, I think, in what we're doing overall. That's the slides I got. We want to talk, I'm going to actually go back a bit. We want to talk some more about the CWIS score and do some examples. And one of our nurses has volunteered, Frankie Alpha, to demonstrate this. Should we do questions first, you think, or after him? Let's do any questions. Look at that. No questions. That's perfect. Ma'am.
Yes. Before you ask, Jim, you repeat the question just to make sure it's heard.
Thank you.
Oh, okay. I was just thinking that when a patient first comes in, I kind of hate to give them trazodone just because it kind of masks the Librium. So that first night or two.
I think that's really smart. The comment Patsy made was during the beginning of their treatment, they're less likely to give trazodone, the sense we might be hiding the symptoms of the alcohol withdrawal, and it'd be better to use the benzodiazepines. And I agree 100%. Almost all these supportive meds, right, can reduce the CWIS scores. I've taught how this reduces symptoms, that reduces symptoms. The CWIS scores will be lower, right? So if we're giving the benzodiazepine per the CWIS score, they'll get less benzodiazepine. In the early part of their stay, the first couple days, our best thing is to be aggressive with the benzodiazepine, because that's what's going to prevent the seizure and the DTs. As they start to get better and we're trying to wean them off, particularly for the anxious sort of patient, or the patient who's very fussy and wants a lot of meds, I think the other meds play a big role. But when I'm thinking about what should I do, should I give some Seroquel or give some Librium? I think, how long has the guy been here? When was his last drink? If it's 24 or 18 or 36 hours, I'm going to reach for the benzodiazepine first. If the guy's been here for a while and he should be coming down by now, I'm more quick to go with the other supportive medications. I agree. Thank you. Any other questions?
We used to use Tegretol a lot before, but I haven't seen any in use anymore.
So I'll tell you why we made that change. So we had a patient come up to the unit who was drinking a lot of alcohol, also taking a lot of Valium. She was also a very large person, about 300 pounds. And I was very disappointed to see it about 2 days into her process, she had a seizure. She was on the Tegretol, 200 milligrams TID. I checked her Tegretol level, it was like 1 or 2, not enough. So I found myself not really sure what to do. How do you adjust Tegretol per body weight? And I couldn't find any published literature on that. I talked to a neurologist. I gave her another loading dose, another 400 milligram dose, and the hope would be okay. And the next day she had another seizure. So I checked her level again, and her level was like 2. 6 is a therapeutic level. So I was like, oh, this is not working out. I had remembered that I had an old article from Psychiatric World that had adjusted Depakote per body weight. So I ran her through that to see how much Depakote she'd get, and it was a lot. And it was obvious to me we were under-treating. So I like the Depakote better, not because I think it's therapeutically better, but I think it's adjusted more for body weight. So for people who are extra big or extra small, it's going to be closer to the right dose. All that being said, we should check levels and keep an eye on it. And a lot of the older patients, especially people on multiple meds, will have very high levels occasionally and can have complications from that. So that's why I made that change primarily.
So who would you consider to be an ideal candidate for Tegretol?
So the question is, who would I use the Tegretol in lieu of the Depakote? It's the patient for whom there's drug interactions. And there's the seizure meds have a lot of drug interactions. And this can be a really problematic thing. If you're on Coumadin, that's not so rare. Depakote and Coumadin can be really problematic. Tegretol and Coumadin can be a problem too, but as I read it, not as bad of a problem. Lamictal, we talked about how Lamictal might be effective in this regard, but never been proven to be effective. So if someone's on some Lamictal and their problem's bad enough that I still want the Depakote or Tegretol, you can't really give Depakote with Lamictal. So I'll give the Tegretol instead. If someone says, I hate Depakote, it makes me feel X, Y, or Z. Well, okay, we won't give you Depakote. But I typically will try to use the Depakote first because I like the adjustment per body weight, and that's really the reason. There's actually a slightly more research using Tegretol, a few more published research articles, but not a lot more. They're pretty comparable. If I have a patient who comes in with issues, or with medical issues that the Depakote might be a problem for, if their ammonia level's high or their platelets real low, I might swing toward the Tegretol. On the other hand, if their sodium level's real low, I might swing back towards the Depakote. So kind of drug interactions and complications are how we decide that stuff. Any other questions?
How come they have to wean off of the Depakote sometimes? Like I see people get discharged with like a taper.
That's a funny question. So the question is, why wean off the Depakote? And they probably don't have to wean off the Depakote. So this is a little bit embarrassing, but I'll tell you why I did that. The research articles around alcohol definitely gave Depakote or Tegretol for 6 days. Some were 5 days, some were 10 days, but typically 6 days, and then they just stopped it. Right? And that's how we did it for a long time. This is using Depakote or Tegretol to presumably help the alcohol withdrawal. Now, there was one small study where they actually had a group of people who got Ativan and a group of people who got Depakote, kind of randomized. A really good article, right? Not a ton of patients, but some. And I was really excited by that. These are all low-risk patients. But the folks who got Depakote actually felt less anxious. They slept better. That was cool. What I really loved about that article was they were less likely to drink when they left the hospital than people who got Ativan, and that was very exciting to me. Right? But of the people who got Depakote, it's only about 30 or 40, they had half of them keep taking it for 6 weeks, and half of them just stopped it at 6 days. And of the people who took 6 weeks, they were half as likely to drink when they left the hospital. I was very excited about that. But I still wasn't sure what to do, because if you stay on Depakote, you have to do some monitoring. You have to watch for liver problems and platelet problems and check a level. And that's hard to do for us because we're in the hospital setting. But the real reason was I was talking to a neurologist one day, and I think it was about that lady who had the seizure on Tegretol, describing what we do, and he thought that was crazy to stop it abruptly. So even though I think the evidence base supports giving it for 6 days and just stopping it, the expectation of physicians in the community that'll taper it off, that you'll do that, and there might be some added efficacy for helping people not relapse once they leave the hospital. So I really taper it down for that reason. I think it's probably helping symptoms a little bit, and I don't want to get beat up by a neurologist. Okay.
Can you more about the relationship between alcohol and elevated ammonia levels and progressing to hepatic encephalopathy, and also treating with lactulose and how lactulose acts in its treatment.
So the ammonia thing with Depakote gets mixed up with the normal problem that some alcoholics have of hepatic encephalopathy. If you drink, liver cells will die. They're very sensitive to alcohol. So liver cells die, which isn't that bad though, because liver cells regrow. How wonderful is that? So they die and then they regrow and they die and they regrow and they die and they regrow. And just when that, like in your skin when that happens, you get scars. And so after a while of doing that, you'll get scarring in your liver. And that's what cirrhosis is, that's scarring of the liver. The liver works like a sieve, a filter for all the blood coming out of your guts, your intestine, your stomach, and everything has to go through there. And if there's a lot of scars, the holes of that filter get plugged up. So there's a back pressure. And after a while, the blood will start to find a way around. There's a few places by the esophagus where it can find a way back to your system, or by the rectum, you get hemorrhoids. There's a few places that blood will get a way around. Now, ammonia is a breakdown product of protein metabolism. And amongst other things, your liver is supposed to get rid of that. And if the blood stops going through the liver, the ammonia won't get gotten rid of, basically, and the ammonia will build up in your system. This is the same ammonia you clean the floor with. How weird is that, right? Okay. And when people get this high ammonia levels, they're often goofy and sleepy and obtunded, right? And they call that hepatic encephalopathy, which is Greek for your head is messed up by your liver, okay? Right? So it's not entirely clear if the ammonia is the cause of the hepatic encephalopathy or there's some other product that builds up in your blood or whether it just goes up with it. But we find if we make the ammonia go away, some people wake up and get better. And we make the ammonia go away by giving you lactulose. Lactulose is a simple sugar that your body cannot absorb. And when you swallow it, or give it rectally, it travels through your intestines and it sucks water behind it. And as it sucks water behind it, it also sucks ammonia behind it. Right? So if you drink lactulose, the lactulose runs through you, it sucks water into your intestines, and it sucks ammonia into your intestine, and it'll help you poop out some of that ammonia. The problem with lactulose is it causes terrible diarrhea. And in fact, it will not get rid of your ammonia unless you're getting terrible diarrhea. So you have to have diarrhea, which is why patients always stop taking their lactulose when they leave the hospital. It's a helpful medicine for constipation. Constipated patients like that. But for people who aren't constipated, they really hate it. So people with hepatic encephalopathy, that's the guy with the ascites, and the jaundice, who's like acting real weird even when he's not drinking. He gets admitted, put on lactulose. Often they wake up after a couple days. They usually stop taking the medicine when they go home. However, if they quit drinking, often their liver gets just better enough that this problem gets better. Now, that's hepatic encephalopathy, basically liver failure, end-stage liver disease. The ammonia in Depakote's a different phenomenon because the cause of this is a little vague, but it has something to do with some part of the ammonia metabolism that happens in the kidney. I read it, I honestly didn't understand it. But it's a genetic variant that some people with certain genes are prone to have this happen with Depakote. It will happen to those people reliably. It can happen to people who do not have a bad liver. Right? And it's not necessarily more prone to happen to people who have a bad liver. It's a more or less random event. We started checking it routinely because we had a few curious cases, and we felt bad about causing a complication. So I don't know if it's something we should check every time or we can check intermittently. But for example, we had this one person who was 100 who went to the ICU and slept for 3 days because we couldn't wake her up. She actually turned out fine in the end. But I had one elderly lady we started on Depakote. She was coming off, I think, Soma pills. And on day 3, she felt fine, but her ammonia level was 100. I chickened out. We stopped it and switched to Tegretol. Tegretol doesn't cause that, right? That's a problem specific to Depakote. So we changed because we had a side effect. So I don't know whether that ammonia of 100 would have knocked her out or whether it would have caused no harm whatsoever. It's really pretty confusing how that all works out. Okay. Any other questions?
So then if you give them the lactulose and they're having the diarrhea, how does that affect their electrolytes? Do you have to be too concerned about that?
You know, that's a great question.
Fluids, IV fluids, or...
Yeah. So the question is are they going to get dehydrated or have bad electrolytes from the lactulose? It's very rare that lactulose would be dehydrating. Usually the diarrhea is not good enough for that unless they're pukey too. Diarrhea can cause low potassium. I haven't seen it in a patient on lactulose, and I honestly don't know, but I think it's a good idea to watch their lights more carefully. Watch their electrolytes more carefully. Yeah. We should probably...
Why we're giving Ativan to people over the age of 60 instead of Librium.
So the question is why give Ativan to the elderly as opposed to Librium? So as you get older, your liver slows down. And even a pretty healthy person who's robust, who runs marathon races, people cross that 60 to 70 line, their liver starts to slow down. In alcohol withdrawal, particularly in the early stages, I said we want to treat people pretty aggressively. And sometimes we give a little bit too much, right? And that's not necessarily wrong by any means. It's better to give too much than too little in those first 24 hours. But if we give too much Ativan, they'll wake up in the morning, and if we give too much Librium, they'll wake up on Thursday. So particularly for people who are likely to have slower metabolism, I prefer to use the drug that if we overshoot, we'll back off. Sometimes if they're doing well, I'll switch them. So if I have a patient who's day 2, they're not getting that much Ativan, I might switch them to the Librium because I can tell they're going to do fine and not need that much. But if I think I might need to treat them aggressively, and we face that early in the stage, I prefer the Ativan because it gives us a little more room in case we overshoot. You asked me to talk about why we combine it sometimes, right? And that's a good question. So remember, Ativan's in and out fast. Librium's on slow and off slow, right? So if someone's unstable and they're combative and they're swinging at the nurses, we want to get some medicine there fast, right? But what sometimes happens is one shift gives a lot, and the nurses come on the next shift, and the guy's totally zonked. He doesn't need any, right? So they watch an 8-hour shift, and he wakes up at the end of his 8-hour shift, and he's flailing again. And so you get this kind of oscillation. The Ativan is safer in a way if we're giving it aggressively because we don't have to worry about overshooting as much. But the Ativan wears off and can leave the person in the hole down the next shift. So we'll sometimes combine it, right? Now this is fairly arbitrary. Again, I picked this up from Sandy, the nurse, who recommended I do this. But what I'll sometimes do, if they're taking a lot of benzodiazepine, I'll take about 1/3 of it and I'll give it as Librium. Now, 1 milligram of Ativan is equal to about 25 of Librium. So if I have someone who gets, they got 24 of Ativan, which isn't crazy high, but it's pretty high. So I might say 24 of Ativan. 1/3 of that is 8. If 1 milligram of Ativan is 25 of Librium, that's about 200 of Librium. So I might write an order like Librium, 50 milligrams PO Q6 hours, hold if the patient's somnolent or sedated, or respiratory rate below 12, and Ativan PRN CWIS score. And what I'm trying to do is prevent them falling in the hole, kind of smooth things out a little bit, while still giving the nursing staff who's present with the patient the opportunity to respond to the peaks and valleys. And that's worked out really, really well. And we've had less of that, somebody escalating off the next shift. I try to write those orders just for 24 hours at a pop, because I've sometimes seen that the doctor writes that order and forgets about it. 4 days later, the patient's all better, and they want to discharge them, and they've been taking Librium each day, so they haven't really weaned them off properly. So I try to write them in 24 hours, but again, this is a thing that was recommended to me by a nurse, and feel free to recommend to your doctors to consider as an option. Any other questions? Yeah.
About pregnant women and the physiologic changes going on in their bodies and the men.
So this is much harder for pregnant people, but not terribly much, because benzodiazepines, you'll read that some are category D or they're associated with birth defects. That data has been mostly questioned or thought not to be true. Benzodiazepines probably are not dangerous drugs in pregnancy. We don't want pregnant women to seize. Seizures are associated with birth defects, probably via hypoxia, right? We don't give the seizure drugs. Most of the other medicines are of questionable safety. Haldol's probably pretty safe. Vistral's certainly safe. Trazodone probably safe. But for the most part, you do the same thing, right? If someone's late in their pregnancy, when the babies are very fragile in the 3rd trimester, I might lower my CWIS score. Give them something if their CWIS 4 or 6 or something like that. If someone's early in their pregnancy, when the baby's more robust, I might be less worried about that. But mostly it's the same. Any other questions? Okay. Well, let's stop. I'm going to ask Frank Kalfa, is that right, to come up and talk about the CWIS scores a little bit and how you might do them, and then we're going to have some sample patients.
The CWA Institute Withdrawal Assessment is referred to as the CWA. It's composed of symptomology scales. Some are rated by the patient and some are rated by the observer. And what I'm going to do is I'm going to go through each scale with a patient and rate the scores. And do I have my first patient?
Should I introduce myself?
Yes.
So I'm a 57-year-old guy. I've been here for about 2 days or so. I've gotten 250 of Librium yesterday for the whole day. And I was in the hospital before for alcohol withdrawal for quite a while. So that's all.
And I'm Fran. I'm going to be your nurse for today.
Hi, friend.
Hi. How are you doing?
I'm okay. How are you?
Okay, I'm okay. Thank you. I want to know, are you experiencing any nausea
Yeah, I threw up this morning.
Okay.
Yeah.
Uh-huh.
I don't know, but I think the eggs were a little heavy.
All right. So are you still nauseated?
Maybe a little bit. It's
little
getting
bit.
better.
So how would you rate that on a scale of 0 to 7?
Let's call it a 4.
A 4, okay. Do you have a headache?
Yeah, I got a headache. Can I have some Tylenol?
Sure.
Thanks.
How would you rate that on a scale of 0 to 7?
Oh, it's not, maybe 2.
And I'm checking to see if you have any sweating. Do you feel sweaty at all?
Yeah, it's hot in here.
It's hot in here, huh? Uh-huh. It looks like you have some beads on your face.
Yeah, I
uh-huh.
feel really sweaty.
Yeah. Are you seeing anything unusual, or do these lights seem brighter than usual to you?
No, it's okay.
It's okay?
It's okay. I couldn't find the light switch this morning.
You couldn't find it?
Yeah.
Uh-huh.
These rooms are
So,
kind of weird.
so are you seeing anything on the sides, periphery, or anything moving, or spots, or anything?
No, I don't think so.
Okay.
Is there something moving here?
No, I don't think so.
Okay.
So does my voice sound louder than usual?
Yeah.
It
everything's-
does.
And I heard them laughing at the station. I don't think they should be laughing about this
okay.
like that.
So, is there anything else you've been hearing?
No, I don't know.
Okay.
It's been noisy up here.
Okay.
You guys come in the middle of the night and it's like banging and crashing?
A little, yeah.
Yeah.
If I touch your skin, do you have any unusual sensations like pins and needles or
It's switchy.
twitchy? Okay. So your skin feels a little uncomfortable or
It's weird.
unusual? Okay. How would you rate your anxiety? Do you feel uneasy or anxious?
I'm worried. I've been trying to call my wife and she doesn't answer the phone and I'm kind of freaked out about it. When the bills, when we came in, the bills were paid and I don't know what's going on at home.
Okay, so
Anyway. I'm
other
just
than
worried
that,
about
do
it.
you feel anxious about being here or
Well,
in
I
general?
wasn't planning on staying in Swan, and I just don't know what's going on at home, so I'm really worried about it.
Okay. Now, I would look at the patient and I would try to note whether the patient is restless in bed, moving around a lot, agitated, things like that. And I want to ask you one more thing. Could you stick your hands right out like that and spread your fingers, please? Okay. Looks like you're pretty shaky there. You feel shaky this morning?
I was trying to get my coffee and then.
Yeah. Okay. Can you tell me your name?
But Jim,
Jim. Okay. Can you tell me today's date?
it's September, yeah?
September. Uh-huh. You know what year it is?
Yeah, it's 2000, 2008.
Okay. And what day is it?
Is it Tuesday?
Uh-huh. Date?
Oh. 2025.
Okay. Okay.
Is that right?
It's okay.
Okay, thanks.
Do you know where you are?
No, I'm at the hospital.
Okay. What hospital?
The Ballard Hospital.
The Ballard Hospital, okay. And can you count forward from 0 by adding by threes?
What?
Adding by threes, like 0, 3, then add
Oh, okay. You want me to,
count.
okay, 0, 3, 6, what are we doing?
We're adding by threes.
3, 6,
That's
6,
okay.
9.
Yeah, okay,
Is
okay,
that
good. Yeah, that's
Okay,
very good.
thanks.
Okay, that's been very helpful. Now I'm going to go and check and see how much medication I can give you to make you feel more comfortable.
I feel awful. I really appreciate
Yeah,
something.
you look uncomfortable.
Thank you.
Thank you. Okay,
I'll stay here.
you'll stay there, okay. So I got a CVOS score, a very high CVOS score. So this gentleman is in severe withdrawal. And so what I would do at this point, there is an algorithm that's already set up by the physician for medications. I would go and I would check the algorithm for medications and I would decide Which
Granny,
medication?
take your finger off the remote.
Yeah, you're
Oh,
beeping.
yeah,
Beep it.
all that.
There you go.
You're okay.
So at this point, I would check the algorithm and I would try to figure out from that the amount of medication that would be appropriate to medicate the gentleman to make him more comfortable and to manage his withdrawal symptoms appropriately.
So curiously, what did you get?
I got over 40. So, yeah.
And this is a guy who could be like 6 hours later in 4-point restraints in really, really bad shape. So, and when you see someone as sick as this, you might want to think about switching to the Ativan scale and just ask the physician for aggressive orders so you can treat them hard and get it settled down.
And it doesn't take much when you have a scale of 7 to come up with a lot of 7s. So, thank you.
Fourth, isn't it?
Good morning.
Good morning.
I'm Fran. I'm going to be your nurse today.
Nice meeting you.
Nice meeting you.
Should I set the...
Sure, go ahead.
Can you hear me? I'm 34 years old. It's day 3. I came in using 6 to 12 bottles of beer a day. And I had 125 milligrams of Librium yesterday.
How are you feeling today? Did you sleep well last night?
I slept great.
Great. Have you had any nausea or headache recently?
No. No reason, no.
None? Do you have any sweating? I'm going to check your skin. You don't feel pretty dry there, huh? No sweating at all? No? Okay. Have you noticed that the lights are brighter or any kind of visual disturbance at all?
No.
No? Okay. Does my voice sound louder than usual, or are you hearing anything unusual?
No. Voices seemed loud yesterday, but
Not
today.
today,
It's
okay.
normal.
So when I touched your skin, did it feel unusual? Do you have any pins and needles or anything like that? Any unusual sensations?
No.
None? Are you feeling anxious or uneasy?
Well, I'm really wanting to get back to work.
Wanting to get back to work? Okay,
So I would like to get out of here as soon as possible.
okay.
But aside from that, no.
And I'm going to notice that he looks like he's relaxed. He's not moving around in bed. He doesn't seem restless or agitated. I'll give him a 0. Could you put your hand straight out for me, please, and spread your fingers? And there's really a minimum amount of withdrawal. I mean, I see a little bit of tremors, minimal. Could you tell me who you are?
My name is Travis.
And do you know today's date
September 30th,
and the year?
2008.
Okay. And can you count backwards, or actually count forward from 3s by 3, so 0, 3, 6?
0, 3, 6, 9, 12, 15, 18.
Okay. That's going to help me a lot. I'm going to go and check on your medications
Okay.
and see if there's anything I need to give to you. And I'll check back with you.
Do you let me know if I can be discharged?
Yes, and I'll check on that. So I got a very low score. I got a score of maybe 4 at the most because the anxiety was the highest. So he probably wouldn't be eligible for medications. Or maybe something for anxiety, minimal, maybe not.
Maybe just let him
Can I ask a question? Fran, sometimes I hear you tell nurses to have the patient stick their tongue out.
I only do that in cases where it's really marginal and it's really difficult to assess whether the patient is actually having real tremors or no tremors.
You know,
Some-
sometimes, sorry.
Some patients will feel uncomfortable and want medications, so they will appear to have a lot of tremors. Another thing you can do is you can hand them a glass of water and ask them to take a drink of water to see if they still shake a lot. There's different ways that you can assess that to see what the actual level is. But that's only in cases where it's difficult to assess it.
Any other questions?
No.
Microphone again.
Oh, yeah. Hey, Frank, come stay by that microphone.
What do you do with a patient who's unwilling to cooperate? Which is
I'm
probably
not-
a,
Come stay with me. Share our microphone.
Yes.
Yes.
It depends what that means exactly. You know, it's really important, you know, people come to quit drinking, and they are by nature ambivalent about that, right? So sometimes they will change their mind and not want to stay, or not want to participate. And if people are competent, meaning they can more or less understand the risks and dangers of their decisions, we're supposed to honor that. So for the most part, we're supposed to defer to the patient's choices. There are times when people are very delirious and very, very unsafe. And there are times they have to be kind of kept here against their wishes, truthfully. The legal threshold to do that in the state of Washington is very, very high. So we try to avoid it at all costs. Patients will typically be very cooperative with the kind of surveying of the symptoms. Fran was kind of talking about how there are patients who've been in, particularly they've had a number of psychiatric hospitalizations. They're of the opinion that the world owes them benzodiazepines, because that happens in a lot of hospital facilities. And sometimes there comes a little bit of contest about how much they're going to get, and then we'll try to use some objective measures. I like to watch the pattern though. After the people reach the peak of their withdrawal, second, third, or fourth day, it should come down every day, and you can look at how much medicine they had yesterday to kind of get a rough sense of what you expect to happen to them.
I've always found that having them stick out their tongue, I never can see the tremors at the tongue. It's very rare. So is it really that pronounced?
I don't know, actually. I've never done that.
Has it been pronounced when you see it?
I've seen some patients have tremors in their tongue, but it's not really,
Subtle?
it's subtle, and also it's not always reliable, so that's why I have them hold a glass.
Hold the glass.
After they're paralyzed, you know, we check to see if there's chest vesiculation. It's very fine. I mean,
So I have another way of reassessing, which is not in the CWIS score, really not evidence-based. I'll do their reflexes, and people in alcohol are typically a little bit brisk with their reflexes.
Well, thank you. I say we give them a big hand.